Welcome to my YouTube channel. Today we are going to talk about acute exacerbation of COPD. So, acute exacerbation of COPD is a clinical diagnosis and where you have increased of the cardinal symptoms of COPD. So, you'll have increased shortness of breath, you'll have increased cough, you'll have increased dyspnea among others. So the etiology is obviously triggered and usually mostly viral infection, that is the rhinovirus is the most common. You could also have influenza and COVID-19. Bacterial infection is usually Haemophilus influenza, Streptococcal pneumonia, and Pseudomonas aeruginosa. So this one is mostly usual when a patient has a long hospital stay. So if you have noticed this and if you have watched my previous video on COPD, then you will notice that this patient is that's why we vaccinate these patients. That we vaccinate from the most common. We vaccinate influenza, COVID, and pneumococcus. Sorry. So clinical features we have diffuse wheezing, distant breath sound, Barrett's chest because of the hyperinflation, tachypnea, tachycardia, and patient has a history of smoking for greater than 20 years. So features impending of respiratory failure is this when you have a patient who has inability to maintain respiratory effort, there's cyanosis, there's hemodynamic instability, and you have depressed mental status. So classification for severity of COPD exacerbation. So a patient now who is suspected of COPD exacerbation, obviously you have to consider other things. For example, differential diagnosis. Do they have heart failure? Then you do a chest X-ray. Do they have pneumonia? You do chest X-ray. Do you have PE? You do CT angiograph. And then if then you treat according to the appropriate treatment. However, if now you confirm the diagnosis of COPD, acute exacerbation of COPD, and now you categorize the severity could be mild, moderate, or severe. In terms of mild, then we have a dyspnea of the greater than 5, respiratory rate of less than 5, respiratory rate of less than 25, 24 breaths per minute, heart rate 95 breaths per minute, respiratory oxygen saturation of greater than 92, and CRP of less than 10. And then moderate, the symptoms will keep increasing, and then severe will have dyspnea, heart rate, heart failure, SpO2, and CRP is same as normal. However, this ABG shows new onset worsening, hypercapnia, and acidosis. So then later now you can determine, after now treating, you can determine now what was the cause, what was the etiology. We do viral testing, sputum culture, and among others. So these are the differential diagnoses I've said before. If it's pneumonia, do a chest radiograph and you see consolidation, that is the lung patch infiltrates. And then pulmonary embolism, you obviously clinical suspicion where you have hemoptysis, previous history of surgery, fracture, history of cancer, DVT. You could also do the DMS or CT angiograph as mentioned before. Heart failure, you do a chest radiograph or you do a brain natriuretic peptide or an echograph, and then pneumothorax infiltration test radiograph where you see the infiltration of the, you can also see the cosophronic angle, and you can also do the rectic ultrasound. So in terms of myocardial infarction or cardiac arrhythmia, you do an ECG and troponin. So management, obviously this is an acute, this is an emergency. You do ABCD, airway, breathing, circulation, and disability. After you have addressed that, now you give supplemental oxygen, that is, and your target is 88 to 92. Later you give bronchodilator therapy and ventilation support. So if this is bronchodilator therapy, and according to the severity of this patient, if they require ventilator support, then the most preferred one is the non-invasive ventilation. However, if non-invasive ventilation is contraindication or the patient is worsening symptoms, then you go to invasive ventilation. So the non-invasive ventilation is preferred obviously with patient with severe exacerbation unless intubation is required or contraindication. So contraindication is where you have impaired consciousness, inability to clear secretion, high aspiration risk. So kindly note, the modality of non-invasive ventilation that is used is BiPAP. That is bi-level positive airway pressure is preferred compared to CPAP or any other. Next is worsening or an improved. When now you have worsening or an improved gas exchange or a pH of less than 7.25, then this is an indication for severe. This is an indication for invasive ventilation. So the invasive ventilation, you have tracheal intubation and mechanical ventilation. This is when you have acute respiratory failure and hemodynamic stability, plus the contraindication for non-invasive ventilation, which we said are impaired consciousness, inability to clear secretion, and high risk of aspiration. So the diagnostic testing you do assess oxygen saturation using a pulse oximeter. You do ABGs. You do not assess the peak expiratory flow rate or spirometry in acute severe COPD exacerbation. You just do a portable chest X-ray to rule out the signs of pneumonia or acute heart failure or pneumothorax. These are differential diagnosis. CBC electrolytes BUN, that is urea creatinine. You can also do cardiac troponin, where you are ruling out the differential diagnosis. ECG, where you're ruling out arrhythmia, ischemia, or pulmonary. So this is the management for severe but not life-threatening exacerbation. You assess the severity, as I mentioned before. You do blood gases, as I mentioned before, and also chest X-rays, as I've mentioned before. You administer supplemental oxygen. We have said this before. You obtain serial ABG and venous gas. So the bronchodilators, you increase the dose or the frequency of the short-acting bronchodilators. You combine the short-acting beta agonists with the short-acting anticholinergic, and consider long-term acting bronchodilators when the patient becomes stable, and then you use spacers of air-driven nebulizers. You can also consider oral corticosteroids. You can also consider antibiotics when there's signs of infection, and consider non-invasive mechanical ventilation, which one is used? The BiPAP. And at all times, you monitor the fluid balance. You consider subcutaneous heparin. This is for thromboprophylaxis. And then you identify and treat associated conditions such as heart failure, arrhythmia, and pulmonary embolism. So indications for medical or intensive care unit admission. This is when you have worsening symptoms and the patient is not improving, or your dyspnea of that responds to inadequate severe dyspnea that inadequately responds to the initial emergency treatment, changes in mental status such as confusion, lethargy, and coma, persistent and worsening hypoxemia, and worsening respiratory acidosis for less than 7.25, despite giving supplemental oxygen and non-invasive ventilation, that is BiPAP, and then need for invasive mechanical ventilation after this aspirin, and then hemodynamic stability, where the patient needs vasopressors. So indication for the non-invasive mechanical ventilation, I've already said before, at least one of the following: respiratory acidosis, which is pH of less than 7.35. However, not if it is greater than 7. If it's less than 7.25, you go to the invasive. Severe dyspnea with clinical signs suggestive of respiratory muscle fatigue, increase in work of breathing, or both, and use of respiratory accessory muscles for respiration. Persistent hypoxemia despite supplemental oxygen.